like to take this opportunity to introduce to you Dr. Stanley Adkins. I've had the pleasure of calling on Dr. Adkins as a nurse and as a individual working in the cardiovascular arena in the sales area. So while working for Boston Heart, Dr. Adkins has become near and dear to our company, as well as taking care of many patients and pilots. So Dr. Adkins practices in Indianapolis, Indiana. He's an internal medicine physician. He's a senior air medical examiner for the last 15 years. And he specializes in cardiac disease in pilots. He has an interest in heart attack prevention and multimodality testing. So please welcome Dr. Stan Adkins.
Thank you. Thank you for putting up with us here. We enjoy it. We have a group of people again here if you wish to talk to them at the end. There are people back here, people over here that know a lot, and then the gentleman that wrote the textbooks, so he knows an awful lot. What we're going to do today is overview how we use this information. I am a pilot also, so when someone comes into me as an AME, we're going to have a discussion first of all about being an AME and them getting certified. Then the FAA allows me to take my metaphorical hat off when we're done and tell them what they need to know. As a matter of fact, the FAA encourages us to spread the information that we have. And also the FAA says that once you take your metaphorical hat off, it is not FAA information any longer. The examination has been done and is finished. And that helps a lot of pilots understand that we're not poaching on the information. We're not going to turn around and turn it in. Now, if you said, hey, Stan, I'm going to go kill somebody, I probably will mention that to somebody. But as far as cardiovascular disease, it's a big deal because it is the number one. There we go. I'm still learning to drive here. Okay. I'm a farm boy. I was born in northern Indiana. I was reared in Indiana. Spent a couple years in the Air Force. And they were winding down Vietnam at the time. I was a medic or doc in the Air Force, and so they kicked me out because they didn't need docs anymore. What we do in our office is actually primarily heart attack prevention work, which at our level isn't terribly hard because it isn't Dr. Serperco's depth. It's what we do every day, and it's far more superficial. And then we get people to Dr. Serperco. So we're talking about the diagnosis, control, and regression of atherosclerosis. Did you know you could reverse atherosclerosis? Bet you can. In fact, it's not that hard to do. The problems are we don't know that we can do it in everybody, and it becomes complicated because, as the doctor mentioned, there are many reasons why it can occur. This is cholesterol and inflammation. Russell Ross, back in the early 1970s, said there were two legs to the problem of atherosclerotic disease. One leg was cholesterol and the other leg was inflammation. Well, back in those days, we didn't have real good tests for inflammation, but we knew how to measure cholesterol. So we went down that path. And most of the information that you'll get out of the Boston Heart Diagnostics is based upon lipid research. The gentleman that started Boston Heart is Ernie Schaefer. Ernie has no credentials to his name. He was the head of the heart, lung, and blood part of the NIH, and he also has published over 500 papers on cholesterol and heart disease. I don't know how many Doc has published, but of that nature also. So these are the people that actually have done the work in the last 30 years. Then the inflammation part came along, and so now we know that, in fact, cholesterol causes inflammation. So there's this interplay between these risk factors, and we're very interested in them because we have strokes and we have heart attacks. A heart attack is a stroke of the heart. A stroke of the brain is a heart attack of the brain. They're the same disease process, excluding high blood pressure strokes in the brain. And you might tease some other options out of it, but basically This is the issue. 2 million heart attacks and strokes, the number one cause of American deaths, 800,000 annually, and it's been the same for 100 years. We haven't changed anything. We're getting a little bit better at it, but it's still the number one cause. Here we have Michigan. This is a football stadium, right? The attendance that particular day is 109,318. To point out the fact that 100,000 lives could be saved just by lifestyle changes. And Peg will be speaking after lunch about lifestyle. It is a big deal. Lifestyle is more important to the prevention of death from cardiovascular disease than everything else put together. It's that big a deal. Here's a book I recommend to you. Brad Bale is and Amy Doneen are interesting people. He was a family physician up in the Northwest somewhere in the late 90s. And basically, what docs do with medications is try them serially. You use one drug, if that didn't work, you try another one. If that doesn't work, try another one. One night, he was at home being philosophical about this, and he decided to do everything at once that had ever been proven to work, ever. And some things that hadn't been proven. He had one heart attack in the next 20 years, and he was dealing with a high-risk population. The people recommend his book there are Larry King and Tommy Thompson, kind of some big hitters in the world, and he takes care of some very important people, And the issue had been, no one had ever shown that it really made a lot of difference if you got involved, because we were learning at the time. He and Amy actually have a money-back guarantee. Now, if you do what they tell you to, and you have a heart attack, they'll give you back your money. Now, it's not an annuity. It's not like they'll make you rich, but whatever you paid to them, they'll give you back. Why? Because it makes their statistical analysis more realistic. You know, if I can get $500 after having a heart attack, just for telling them I had a heart attack, I will. They haven't paid out a penny in the last 15, 20 years. This is a risk factor page from Bale's book. Now, there are several risk factors. Why would you want to know statistically your risk? Well, maybe you wouldn't. What you want to know is, do you have it? Not does the population your age have it. So the Framingham Risk Group, which is very, very well studied and famous, Reynolds Risk Group, and this is a series of questions that are basically the same type of thing, a little bit more inclusive. And this kind of gets it more down to the individual level as to what the risk is. Why don't people know about the regression of heart disease? Well, it doesn't cost us anything until we get charged a lot. The economy is based upon, this comes from one of my sons who's in the stock market. I was complaining a while back, the stock market was down. He said, it'll come back up, stuff breaks and you have to replace it. Oh, people break and you have to fix them. But you're dealing not with a stock market turnaround, you're dealing with a lifetime. And the choir to get this out to everybody in the United States is pretty quiet. You can see the Kardashians on the news, but you probably won't see Joe didn't die of a heart attack today on the news. That won't make it to the press. This is one of Dr. Saperko's type slides, and it just shows that cholesterol gets a little bit, I was going to say sticky, but it kind of does. It becomes a little bit complicated. We're not going to go through this. The point of it is fancy. This is an artery. And the part of this that's interesting is, as you get down to the end, the volcanoes in the last two sections there, the volcanoes are nasty things. If you're young and your artery pops, it's kind of like Hawaii, the lava running down to the sea. You get a bigger island, you get a bigger plaque. But it generally doesn't kill you. There are obviously exceptions, but if you're older for a bunch of different reasons and it pops, you got Mount Helena, and that one will get you. So 80% of heart attacks come from a 50% narrowing that pops. Doesn't necessarily erode and then trickle down the sides. It can pop. Now, as you go from left to right, you're going to deal with an artery that is normal, and then there are fatty streaks in the aorta, And fatty streaks can be found in children. So if you open up the aorta, say you're taking out their appendix and you want to look at the aorta, you can find cholesterol deposition in the wall of children. That's a bad thing, because it's eventually the plaques will build up and cause them more and more trouble. Oh my, don't you hate it when we're the problem? Lifestyle is the big deal. The scientists have figured out what the big risk is, and it is our lifestyle, it is us. Genetics plays a big deal, there's inflammation, cholesterol, and a whole bunch of things, but the lifestyle needs to be emphasized, and that's what Peg will be talking about later on. 60% of people have some form of atherosclerosis, but most don't know it. Questions. Do you have arterial disease? Do you have the risks for arterial disease? How long are you going to live? Now, that last one is not a joke. That's actually the deal. If you have a family history of everybody died 1 year from where you are, that's a point of concern. If they live to be in their late 90s and died of some unrelated cause, you better take more care of yourself, because now you have to not go to a nursing home for 20 years. My mother passed of dementia when she was 97 years of age. She didn't like that particularly, but what would have happened if she'd had a heart attack or a stroke at age 77 and spent 20 years in a nursing home? Because that is really possible. That's the kind of fear that has to motivate people. You want also some self-interest to motivate them. I don't want to suffer through it in the near term, but you really don't want to suffer through it in the long term. When people are presenting to the office, we're trying to figure out what kind of mischief we're dealing with. We start off with, do you have any disease now? Calcification, any past chest x-ray, dental x-rays. Dentists pick it up in the carotid arteries with just dental x-rays. Ankle brachial ratio is taking the blood pressure with a Doppler in the foot and in the arm and getting a ratio. It is very useful, actually. Aortic aneurysm, if you go to the screening things, the lifetime screening at churches and so forth, one of the things they'll look for is an aneurysm. If they find calcium or hardening of the arteries in your neck, that helps. Calcium score is terribly helpful. But calcium score shows that there has been inflammation, not that there is risk of death. That's the reversal portion that we need to focus more upon. Once the body has been attacked by something, it tries to make it into a bone. So if it's tuberculosis and you see the chest x-ray, there'll be specules of calcium all over the place in the lungs. If they've had atherosclerotic disease for a period of time, you'll see speckles. So it tells you the disease is there. It doesn't tell you if it's active disease at that moment. Treadmill, old-fashioned treadmill testing, it's only 11% predictive, or sensitive, I should say. There are better ways, which we'll talk later. Carotid intimal thickening, that's not the same as the ultrasound they do at the screening. That looks for the amount of narrowing. Thickening of the wall is the real issue, is the wall getting more and more narrow. Brad Bale calls this EDFROG. Education, disease, fire, root cause, optimal care, and genetics. Education. If people don't know that there is such a thing as atherosclerotic disease, they're sitting ducks, because it's there, they just don't know it. So education is number one. Disease. What kind of disease is it? For this discussion, the answer would be atherosclerotic disease. Is it inflamed? Is it on fire? Is the artery hot or is it cold? Both those can be fixed. A root cause. Currently, there are 35 known causes of hardening of the arteries. Number one is cholesterol. Number two is diabetes, or things that will be diabetes, such as insulin resistance. And people with heart attacks, 70% of them have insulin resistance or diabetes. That's the underlying root cause, but they can have more than one cause. For example, if you have psoriasis, you have a multiple increased risk of hardening of the arteries. It's because it's an inflammatory disease. Optimal care, as doctor said, there is no one cause for this. There are treatments, or one treatment for it. There are treatments, but you have to figure out what the underlying problem is first. And genetics, if you have a genetic history, it must be followed. We're not going to go through these except to say these are red flags. if you have these things, you want to pay more attention, and your doctor should be paying attention to these also. But the one at the bottom is a family history of Lp(a). It's a gene. It's a gene found about 20% of a population. It has, a 300% increased risk of heart attack. It is a big deal. It's not only a big deal because of its risk, we don't have a treatment for it. We can lower all the other risk factors, and if you get them low enough, maybe you can kind of turn off the gene, but it's going to get your doctor's attention a great deal if you have an Lp(a). Periodontal disease. The dentists have known this for years. The rest of us haven't. Periodontal disease. In 1987, there was an article finding dental pathogens in the plaque of an artery. Someone took the plaque apart and cultured it, and by golly, there's some dental pathogens, bad guys in there. And so we thought, oh, they must spread in the blood. So there was a short time when the discussion was, well, maybe everybody should be on tetracyclines to prevent heart attacks. Nah, the problem wasn't the bugs, not directly. The problem was the inflammation in the gums to the bugs, and that is a big deal. It dramatically increases the risk of heart attack. So when you're going through the dentist and they're going 2, 3, 2, 3, the dental hygienist says she's checking the depth of the pocket of the tooth, that's actually pretty good for your heart as a test. Waist, this is called the butt-gut ratio. And we'll have a picture of it in a moment. These are risk factors. Started at 3 down at the bottom. You're still alive? Congratulations. Up at the top, yeah, fat ass, you have a low risk, so what? This comes from an angel site, by the way, on the internet. Angel Fire, something like that. I don't think it's religious, but these are the risks based upon the size of the abdomen base to the hips, and it explains the apple-pear paradigm that we've heard for many years about body habitus. The triglycerides more than 150 is a blood test, total cholesterol, HDL ratio. There's also triglyceride, HDL ratio, and age of menarche, less than 10 for a lady or greater than 17. Asthma has a 60%. See how this is gathering steam of things that we want to pay attention to?
Anybody can have a stroke.
And anyone,
Even you.
can prevent a stroke-related death.
someone has a stroke every 40 seconds.
Every 40 seconds.
140,000 people die each year from a stroke.
140,000.
But
You.
you can put a stop to that death count by remembering FAST.
Fast.
The acronym FAST.
F. Face.
Ask the person to smile. Is there a droop in one side of their face?
A is arms. Ask the person to raise both their arms. Does one of them drift down?
S.
S. Speech. Speech. Ask the person to repeat a simple
A simple phrase.
Is their speech slurred or strange?
and T. Time. If any of these signs occur, call 911 immediately.
Immediately.
Remember FAST.
Fast.
And spread the word.
Repeat to defeat stroke.
This is the carotid artery. And with ultrasound, these can be seen terribly easily and very, very well. You can measure the plaques down to 1/10 of a millimeter, basically. And in the old days, when we were doing these, I did about 13,000 of them where we did them on tape and reviewed the entire thing. Nowadays, they're done differently by the radiology department. And what we were looking for was narrowing of the arteries in the neck that we could fix and prevent strokes. Out of 13,000 people, I sent less than 100 for surgery. Not a very good test. But what we did find was that almost everybody over the age of 30 had hardening of the arteries in their neck. You could see it easily. The question then became, was that also in the heart arteries? And the answer was yes. More recently, there have been studies using the ultrasound in the femoral arteries and the carotids and doing this type of thickening of the wall analysis, and it's becoming very accurate, and it helps us know and follow treatment because you can see it go away also. This was a calcium score profile, I guess. look down at the bottom. This is what our gentleman was talking about, Dan was talking about before. Greater than 1,000 is a bit of a problem. And 10 is an identifiable problem because it shows you the process is there. And when you get this, the next step is the artery hot? Remember the previous slide? Is it hot? Is it on fire? Or has it kind of cooled off? Is there disease historically? If, as the doctor said, the biggest risk for a heart attack is having had one already. So is there a historical issue? Is there a disease risk based upon our risk factors that we've talked about? High sensitivity C-reactive protein is an inflammatory marker. We use four different ones in the Boston lab. It is the most generalized, but it's terribly interesting. It more has to do with the plaque burden in the body. If you have just a little bit of plaque, the number will be lower. The higher the number, the more the plaque, which doesn't tell you how a given artery is doing, but it does give you a feeling for how much disease is there. You want the number to be less than 2. We're also going to test, these are various tests that can be done. The heart catheterization is actually called luminology. It shows the opening of the artery. It doesn't necessarily tell you how bad the thickness of the artery is. There are ultrasound techniques for the coronary arteries that will tell you that. But the heart cath just tells you how big the hole is. We have laboratory testing, the Boston, the people who are sponsoring this, coronary imaging by other mechanisms, cath imaging, ankle brachial ratios, the bottom and the center, stress echocardiogram. When you use ultrasound through the chest wall, you can measure the thickness of the heart wall, and you can see if it's moving, which is really important. Another way to do that is the nuclear, which is up in the center. They will inject a nuclear isotope, and basically where potassium goes, it goes. Potassium goes inside heart cells. So when you run this fancy Geiger counter over the heart after you've injected the isotope, it will show you where the blood went. So you take the picture at rest, and then you take the picture with the person exercising, and what disappears from the rest picture to the exercise picture, that's heart muscle that's in real trouble. And that gets cardiologists interested, usually about a 70% narrowing. Cardiopulmonary exercise testing, the one on the bike to the far right, we've done 7,500 of them so far. And what we were comparing it to is the risk in the general population, which the American Heart Association has published for decades, is about 66% of men and 50% of ladies. We're getting abnormalities in about 62% of men and 50% of ladies. And what this shows isn't the 70% narrowing, it shows is there disease present, small vessel disease. And there have been plenty of studies over the last several decades showing that that small vessel disease in the heart, little bitty arteries in the heart, leads to large vessel disease, which leads to heart attacks and strokes. But it gives you an extra 10 or 15 years to deal with the problem. Dyslipidemia. These are the risk factors we alluded to prior, which are population-based risk factors. We use them for our patients and say, okay, you're at this risk at this age, but it doesn't help us to know, does the person have the disease? Monoperoxidase. Now we're starting to get into certain chemicals these are in the Boston Heart Diagnostics, and we have booklets we'll be handing out. In fact, I guess let's pass them out now so they can look at booklets. I don't remember if this is a gentleman or a lady. Rebecca will be passing out. But you'll see the kind of information that Boston will send anybody or everybody that has the test. Because the impression or the opinion is that if the person knows why they're looking at the information, they will do better. For example, if I'm on the glide slope, why am I on a glide slope? Is it the mountain on the left of me? You really need to know extra information. And this gives us extra information. NPO is a chemical that is released, it comes from white blood cells, and if the white blood cells circulating in the blood see a crack and a plaque in the hardening of the arteries. They don't like it. And they release the chemical, the myeloperoxidase. So that tells us that there is a lesion that could pop. The chemical is very potent. It's used to kill bacteria. That's why it exists. It also doesn't like cholesterol. LP-PLA2. This is the close cousin of NPO. NPO comes from the blood not liking a crack in the cap of the plaque. LP-PLA2 comes from the center of the plaque, which is dying, and the body doesn't like that either. If you have a patient that has both of these tests elevated, the chance of having a heart attack in the next year is extremely high. And I have one of these gentlemen. We found out that he was a ranger in Afghanistan and took a bullet in the knee. So he's not terribly active, so he gained 200 pounds. So his lifestyle has now gotten him. He fortunately is extremely intelligent, so we're having good conversations. He'll get it under control. The ultrasound of the neck, there's 4 different classes for the thickness of the plaque in the neck. This is easy to do. A technician can do a very good examination in 5 minutes. And it's reproducible. So the technician does it next week, it's going to be the same numbers. If they do it a year from now and it's changed, that really did change. This is how we pick up most of the atherosclerosis beyond basic testing. It's hard to find people that do it very correctly, but it's out there. F2 isoprostane is kind of a lifestyle indicator, as are certain kinds of the cholesterol that the Boston picks up. There are 4 different types of cholesterol, which will be on your book, and the ones that are at the top are the ones synthesized by the body. The top one of those 2 is basically a lie detector. I put somebody on a statin, and they come back in 6 months, we repeat the study, and it's still up there. They're not taking the medicine, because that test is going to go down. Oxidized LDL is another test, and it really damages things, and it is really an early form of insulin resistance. So this person is going toward the diabetic state. That's important because it's lifestyle treatable, and there are plenty of ways you can treat people with insulin resistance that don't involve insulin. Some of the newer ones out there, Trulicity, you'll see it on TV as a once a week shot. It really does work for these issues. ADMA measures low nitric oxide. Now, nitric oxide, back when I was young, when I was in medical school, was called endothelial relaxant factor. We knew there was something in the artery that made the artery relax, and no one knew what it was. They also knew there was nitric acid. They didn't know what it did. The Nobel Prize for Medicine in 1998 was for the folks that figured out they were the same thing. The body can tell the artery to relax. And if you're looking at the forearm arteries, when you give nitric acid, you can see them open up. University of Texas did excellent studies about this nitric acid. If you remember back to the Olympics that were held in London, they had beet bars. You may not remember that one, but B-E-E-T, beet bars. They served beet juice because the culture and the Olympic athletes at that time was you could open up your arteries and do wonderful things if you drank beet juice. Well, part of that was true. You could open up the arteries in your forearm and maybe other places, but there was no proof of any benefit either in performance or longevity. But University of Texas went to the FDA and said, hey, can we make this into a medicine? The FDA said, sure, you got a couple $100 million of research to do to prove safety and test outcomes. But yeah, you can do it. University of Texas, being a state institution, said, nah, can we sell it as a food additive? And they said, sure. So you can go out and buy all kinds of food additive beet juice, and it's the same stuff. I do not know if it works. It's also used for erection difficulties in men. I have absolutely no idea if that works or not. When you're dealing with some of these issues, there's a 40% placebo effect, so erectile dysfunction. Is that a response that's a placebo effect, or is it beet juice? I don't know. Don't know how you test that one. MACR, a test shows whether or not It's a urinary test. It shows albumin coming out in your kidneys. Now, up in the old days, 2 years ago, thereabouts, the only reason we checked the urine for MACR was to see if the person had kidney damage, and 30 grams of protein in the urine is a bad thing. For men, it's at 3.9, and for women, 7. But that shows early blood vessel damage that's coming along. Again, high-sensitive CRP we've discussed. The LP-PLA2 is the oxidized LDL in the plaque. It's bad. The MPO is the crack in the plaque wall. It's bad. We're going to skip COX-1 and COX-2 for another day. CoQ10 used to be a little bit of magic. Then we got to where we could measure it. And one of the biggest problems with people taking statins is their muscles hurt. And back in my youth, I used to think they were just wusses. This is early on. No, their muscles hurt. It's 1 in 20 maybe. I think it's a little bit greater than that. Some of the figures go 1 in 50, but in any case, it's quite real. So when someone is on a statin, they come in and they say, I hurt, then they do. So you can either change the statin to pravastatin or something that's water-soluble, and that may help. You can stop it for 3 or 4 months and restart it, and a significant percentage can tolerate it the second time, and I don't know why. Or you can give vitamin D3 and about 10,000 international units per day and CoQ10, and I don't know the dose because it's not standardized, but enough, whatever that is. The people who are on CoQ10, if they have an infarct, they have smaller infarcts. So it's got some protective benefit also. And CoQ10 it goes low in people on statins because the statin affects the production of CoQ10 and the muscles like CoQ10. To prevent, again, vitamin D3 and CoQ10. LDL particle number, this is a big deal. There was argument a long time ago, 4 years, 5 years, as to which one of the LDL moieties gave you the greatest information about risk. And the fellow that came up with LDL particle number with nuclear magnetic resonance spectrography was right. So in my practice, 1,000 is considered a break point. 60% of my patients have an LDL particle number more than 1,000. Well, that kind of goes along with the disease incidence in the general population of males of 60 to 66%. So it's really an indicator. 7% also have a marker of bulk, a large amount of atherosclerosis. So they have particle numbers, and it's also doing damage. Markers. The lipid profile, people come in and I'll say, when was your last cholesterol study? Say, oh, my doc drew it a year ago. What did they draw? Well, I don't know. What was your cholesterol? I don't know. And you find out they only had 5 numbers drawn, these first ones, and those are the old-fashioned numbers. And they give you a risk for a lifetime. If you measure when someone's young, you say, okay, this is going to turn out badly in 50 years. The middle set there, those are in less than decades. It's a decade. You see risk. And the ones at the bottom are really bad, the ones we've addressed before. LP-PLA2, myeloperoxidase, that should be a P, not a B. C-reactive protein, MACR. But you can change all this, and we'll do this again in a minute, in about 6 weeks. So you don't put somebody in these medications and bring them back in a year. Nah. Bring them back in 6 weeks and find out what's going on. You drive the car, or in this place, you fly the airplane. Omega-3s were referred to prior EPA and DHA. There is a medicinal form of EPA, and we do use it. There's still some discussion about how much each one of those moieties is worth in the final equation. Beats me. But they're antioxidative, they're anti-inflammatories. The 3s come from the sources there, and too much 3 is not good for you. Oxidized LDL, it measures protein damage. When Doc was showing the different sizes of LDL, and he had the little B on the top, the B is a sticky if you will, for analogy. It holds the LDL to the vessel wall. And remember, cholesterol is a foodstuff. It gets in and various cells use it. So it has to hold on. But more importantly, it's an excellent way to measure the number of particles. So this is also in the Boston book, and they measure routinely. F2-isoprostane is identified because we want to know if people have lifestyle. Actually, smoking is the biggest one. NT-proBNP. There are two ways to have congestive heart failure. You can have systolic or diastolic. Systolic means that the wall has been damaged enough that it can't squeeze. Diastolic is the wall has been damaged enough it can't relax. That's high blood pressure generally. Well, the right heart gets the blood from the body, pumps it to the lungs, goes back to the left heart, pumps it to the body. What happens if the left heart isn't working? Blood pressure in the lungs builds up. You get congestive heart failure. Number one diagnosis in the United States for hospitalizations is congestive heart failure. We have very few medications that will successfully deal with it. We have them. Half of the admissions are diastolic, half are systolic, but they're treated quite differently. The NT-proBNP will go up from either one of those two causes or a rhythm called atrial fibrillation, because it causes a relative congestive heart failure. So this is also in the profile that Boston uses. It's very helpful. This goes to the NMR. Small is bad, as doctor said. Large is better. ApoA1 is bad, and ApoB is high is bad. A1 low is bad. And these are in the booklet you'll be scanning also. Look at all the things that can cause inflammation. How about sleep apnea? Anybody in here snore? Well, if you snore, you've got a significant chance of having sleep apnea. If you happen to be by yourself, you'll never know it. So usually we hear from the mate. Say, oh, he snores, and does he stop breathing? Well, yeah, he does, but then I elbow him and start breathing again. It's a daily almost story. All these other things are pretty well identified, but you see the bottom one is depression. Well, there's a whole cascade of chemicals comes out from the body in response to depression. It's terribly interesting. It's not something people like me can remember, but it's very interesting, and it causes inflammation in arteries as well. 65% of heart attacks are erosions of plaques with rupture without serious obstruction. This is, again, an atoll in the Pacific. You could call it kind of Hawaii. It isn't. But it's to bring up the South Seas. And so we remember Hawaii as being something that is enlarged, not blown up. And, of course, that's the other choice. This one will kill you. There's the rapidity of improvement. You can almost use this as a gauge of whether the person's taking the medicine. Yeah, Stan, I'm taking the medicine. Yeah, sure. Well, then you measure it, and things aren't better in 6 weeks. Either you really miss the diagnosis, which happens, or they're not taking the medication. Regression of plaque can be seen when there is a reduction of ApoB to less than 50, a reduction of LDL-P to less than 900, a reduction of LDL-C, that's total cholesterol, to less than 70. Now, National Lipid Association 2 years ago, this next October, actually said that 40 was probably a better number, and maybe it is, but it's at least worth consideration. Taking a personal thing here, my cholesterol, total cholesterol in medical school is 307. And we were so stupid back in those days, we thought that's probably normal. No, it's in top 1% of the world for death. So when I finally figured that one out, I tried to change things. It's now 80, so I've gone from 307 to 80. My LDL went from 220 to 40. And the hardening of the arteries in my neck that's been present for 20 years is better now than it was 20 years ago. So one of the reasons I really believe in this stuff is I'm living it. This makes me feel a lot better. Alleles of ApoE. Doctor mentioned Alzheimer's disease, ApoE4. You don't want a 4, especially if you're a lady, you don't want a 4. A 3-3 would be normal. There are 3 alleles, so you could have a 2-2, 2-3, 3-3, 3-4, and a 4-4. I have one family, where everybody has had severe dementia by age 75. Everybody in the family is a 4-4. Talk about a real bad selection process. And they're very intelligent, and they all know it. So it brings up a terrible question. What do you do if you're 50 and you know you're going to be demented in 20 years? You buy long-term health insurance, nursing home insurance. And if you have enough extra money, yeah, you go tour the world. But this is a big one. I have a family member with Alzheimer's who is in their late 60s, and it's not pretty. LPPLA2, again, that's the inflammatory marker from inside the plaque. If it gets up to 235, you're sitting right next to a heart attack. Myeloperoxidase, more than 500, you're real close to a heart attack. HSCRP, the bulking thing, it is primarily lifestyle guided, and it's a very generalized marker. So you can have enough osteoarthritis, your knees and hips, this will go up also. I tell people a good sunburn will do it. I don't know if that's true or not, but it's a very non-specific one. Fibrinogen is a marker that is also generally used, but not specific. Homocysteine, you find on some panels, it is an oxidant marker. It marks inflammation, and it is treated with folic acid. Well, not the folic acid that you give pregnant ladies to prevent spina bifida. That's not enough. It's methylated folic acid, and it's available, but it's 50 times as potent as the folic acid, and it does regulate homocysteine, and including the gene MTHFR, which makes the homocysteine. The stiffness of the heart from the congestive heart failure and so forth it's an early marker, but you don't know what it's a marker for. The diastolic part of the congestive heart failure is Arnold Schwarzenegger heart. When Arnold was lifting weights, he got muscle bound. He could not extend his arm because the muscles wouldn't allow him to. The heart gets muscle bound, so it can't relax. It has to relax to accept the blood for the next squeeze. These are the types of things that are in your book. We'll kind of look at this, and you notice a lot of it's red. The reason this is important is because there's colors. If I have someone coming in and they're really not paying attention, I'll show them the colors. Colors make them pay attention. If it's red, it's bad. Don't be red. In this case, the HDL is low. The the protein that accompanies it is ApoA1, which is the next panel down. It's borderline. You go to the Lp(a), which is on the second panel, and it's normal. In other words, they do not have the 20% population risk genetically for this particular marker. We're skipping around here, but you go up to the LDL-P. This person is 930. Good. But now the ones the doc was talking about, the small, dense LDLs. Uh-oh, that's bad. Now the LDL up above the right top is 93. What kind of LDL does this person have? Over on the right side, it says Boston Heart Cholesterol Balance Test. Cholesterol and osmosterol are the ones made by the body. If you start treating that and that cholesterol doesn't come down to normal, that's a lie detector test. They're not taking the medicine. At least that's the assumption. The bottom two are absorption markers. The one that tickles me is, you see where a gentleman are advertised to use beta-cytosterol for the prostates? Then why is it on a cholesterol test? By the way, I'll have to ask you that later. An enlargement of that particular page. Now, when you're going through this with a patient, you're going to spend about 30 minutes boring the heck out of them with this page because you don't want to do it twice. They've got to have an emotional understanding that this is bad for them before they leave the office. Now, when you repeat the studies, notice how everything turned kind of green? That's nice. All of us, even me, understand red going to green is a good thing. This person has an ApoE 2-4. Huh. Does a 2 balance out a 4? No. Going down to a factor 2 and a factor 5 Leiden, those are important for pilots. Any of you that are pilots know someone has had a blood clot in their leg. Sometimes it goes to the lung, but they've been taken off of flying duty because they had a phlebitis. Well, especially B-52 military pilots, they had a significant amount of it because these are pretty common and they clot blood. So, well, if they're abnormal, this is normal. If they're abnormal, they clot blood. So you want the pilot to know that. The one up above, the Silica 1B1, is a TC. That means maybe they'll get by with a statin without hurting, but you won't know until you try it. The cholesterol numbers are really pretty good, except for way down at the bottom, vitamin D. Vitamin D, why would we take vitamin D? Well, in the old days, we did it to prevent osteoporosis, and we put ladies on it. We had the wrong dose. The reason we had the wrong dose was the original studies were done in the late 60s and 70s, and when they went back and repeated the numbers in about 2012, they found out someone missed a decimal point. They were using a slide rule, and we were off by a factor of 10. So now I use 5,000 international units or 10,000. There is a 50,000. Don't use that one. And the Danish researchers, a decade ago, found out if you get the vitamin D level up to 70, this is 26, get up to 70, which is easy, you have a 30% less heart attack rate. It's just too easy. Why not do that? The rest of the things in this are not to get too terribly excited about. This goes back to the complexity of doctors' pictures. This happens to be HDL molecules. And HDL is a reverse transport molecule. It takes the cholesterol from the wall of the artery back to the liver when the liver eats it. The analogy would be pickup trucks. You want a big pickup truck. You want the one at the top, the Alpha 1. It is more effective. There are plenty of research papers showing that not all HDL works the same. So it's just not quite that simple, but that's Dr. Saperko's field. By the way, atherosclerosis regression, if you go to Google search, which does scientific articles, looks them up, you'll find there's 1,170,000 articles as of today on atherosclerosis regression. This isn't new. And we're now in the point of getting vaccines for the PCSK9 sites and vaccines for interleukin 1. The whole field is going to go to monoclonal antibodies at some point. So our grandkids may never have this disease or get immunized at birth or something like that. You and I have to get that far. That again is perhaps my favorite slide. The gut-butt ratio. Have you walked the grounds over here? How many heart attack people did you see walking around yesterday? Lots. They just don't know it yet. But they're out there, which is kind of why we're up here. What we're doing right now is targeting pilots and AMEs, because when's the last time a pilot told an AME the truth? Okay, Paul has told me the truth. I have a very kind friend who's a big boy pilot, and a couple of years ago he came in and he said he had a mitral valve prolapse murmur, and I was listening to it. Now that's wrong. So had him studied, and he had a valvular abnormality, and he needed surgery. So we sent him to a very good cardiologist to work him up for surgery. Cardiologist said, you need a heart cath. I hadn't even thought about that. This guy is about 6'2", maybe 5 pounds overweight, long distance runner. Really? Well, that's why you never argue with a cardiologist. So they cathed him, and he had a 98% lesion in one of his major arteries. So he first of all had vein graft bypass surgery, and then they fixed his valve. Actually, they did it at the same time, but point is, he was doing acrobatics, pulling 5 Gs the day before the cath. How do you get away with that? He had no symptoms, and he was perfectly fit. Now he is perfectly fit. His numbers, of course, came back kind of not correct, and they're normal now. And he just bought an extra, so extra is a plane for aerobatics. So he said, hey, Stan, you want to go up with me? And I'm saying, hell no, I'm not getting that thing. But maybe if I have enough Dramamine or something. The gut-blood ratio is important because you can define people as having three kinds of fat: brown fat, white fat, and yellow fat. Those of you that have taken apart a chicken or turkey, the Thanksgiving turkey, the inside is yellow fat. Yellow fat is an endocrine organ. It makes a chemical called adiponectin. Adiponectin has a whole bunch to do with the way we handle bunches of stuff. It's a big deal. But we didn't used to know that. White fat is under the skin. Take a scalpel, cut through the skin, that fat's white. Brown fat's what babies are born with. That's why when you're changing the diaper, they don't shiver and die of hypothermia. They're making heat. So the question has always been, can you make yellow and white fat into brown fat? The answer is yes. Put them in a room at 52 degrees in a bathing suit for 2 hours, and they will start to make brown fat out of the white and the yellow fat. It is a very limited experiment because you can't keep people in a 52-degree room in a bathing suit that long. But it works. If you don't, they used to say there was such a thing as cryptic, is that the right word? Cryptic stroke. You didn't know where it came from. Is that the right word? Cryptogenic stroke. And so we were trained, okay, if you don't find it, that doesn't mean they didn't have a stroke. It means you didn't find it. So you have to go deep. In this case, you're going to be looking for periodontal disease, which is real, for hypertension that you don't know about really, for diabetes, the interleukin-1 abnormalities which are inherited, Lp(a) inherited, so is 9p21 and KIF6, so is ApoE. Then CIMT is the neck thing, sleep apnea, uric acid for gout. There's been an argument for 30, 40 years that uric acid causes atherosclerotic disease, and it's gone back and forth and back and forth. The current opinion kind of is, yeah, it probably does, because it irritates the arteries, probably. Homocysteine, made by the gene MTHFR. Does homocysteine cause the trouble, or is it a marker? And the HOME-IR is looking for insulin resistance early. If you find no inflammation, all these inflammatory markers are normal. That means there's no erosions. If there's no erosions, nothing's going to rupture. So that's the logic behind here. It doesn't tell you if there's hardening of the arteries in this case. It tells you if they're hot. If they're cold, you're okay. And that's really what we really want. We don't care what the calcium score is as much as we really care, is it an active disease process or is it under control at this point? These are more of the tests. Okay, APO3, 2E. Dietary changes, Peggy will be talking to about this one. Jupiter trial. Jupiter trial was terribly interesting. It was to see if LDL cholesterol was diagnostic or if the HS-CRP inflammatory marker was more effective. And in summary, the LDL-C wasn't the issue, as Doctor mentioned. The inflammation was the issue. And HS-CRP wasn't the best marker, but it's the one they had. Familial hypercholesterolemia, FH, is a very unique disease. It has multiple genetic causes. It's not just one thing. It's what doctor lives and breathes. This kind of cardiology. Your actual cardiologist back home doesn't really get involved in this. They're more interested with other methods of treatment. If you're going to change somebody's behavior, which is what we're all talking about here. How do you change somebody? You know they're going to die. You don't want them to. What are you going to do? When I was in the Air Force, we had senior master sergeants who would come in because they had to get checked out every year on their birthday. They had to run 5 miles on their birthday, and they had to be of acceptable weight. Air Force asked Cooper, who now has a clinic down in Texas, to find out why a whole bunch of senior master sergeants were dying on their birthday. Because they were running. They sat at the desk because they were basic administrative personnel, and once a year they had to go out and jog 5 miles. Bad idea. So Cooper changed everything. He changed it with emotion, with facts, and with word pictures. The art of word pictures. How do you teach somebody what an artery looks like when it's on fire? That sort of thing. Cardiovascular disease kills more people than the next 4 combined. That kind of little information you drop in a conversation. What you're trying to do is get somebody's attention. You can't convince them. They're not going to become converts. But maybe in the future they will. Because they'll go to a party and they'll say, hey, I heard da-da-da-da. And that's how you spread the word. 7.4 million heart attacks in the world per year. Half die suddenly. And that wake up dead is the old saying. 1.6 million deaths, 2.6 million casualties in all the wars that we've ever been involved with. So the real war that we're fighting right now is a disease war. The first line there is from Yoda. It is not to try, it is to do, or something like that. So just believing that we need to save lives doesn't mean we're doing it. 82% of heart attacks, I was wrong on my previous quote, have insulin resistance. That's diabetes. Very few people die of diabetes nowadays. They die of the vascular disease of diabetes. They're still dead, but they didn't die of the disease process. The endocrinologist got that to go away a long time ago. We got all kinds of tools for that one. The drivers of cardiovascular disease, again, are inflammation resulting in erosions or plaque rupture, and there's a bunch of different causes. Inflammation is very common. Actose, I mentioned very briefly. Actose is a diabetes drug. It's also a very strong anti-inflammatory. Metformin hits 2 of the inflammatory markers, and Actose hits 7. The reason we don't use it all the time, it could be, the French found evidence a decade ago that it caused bladder cancer. It turns out that they didn't do a very good job of getting smokers out of the groups, and smoking does cause bladder cancer. So they've been batting around. It may cause a small instance of bladder cancer, but it's an anti-inflammatory. So they're now having to figure out, do you save more people by an anti-inflammatory for the arteries, or do you kill them off with the bladder cancer? I believe you save more of the arteries. This is the Circulation Journal. That's one of the big ones. Doc's published in this one. And this is talking about periodontal disease. And again, the dentists have known this a long time. This guy's a legend. I've never met him. You ever know this guy? In the 90s, he was doing heart surgery, and he came up with an important point. The artery hadn't narrowed down. The artery had popped. And the concept came to him, and he published that the ruptured atheroma was the cause of the heart attack, not the narrowing. And now we know that that's true. Back when I was in school, we were taught that if someone came in the emergency with a heart attack and you could not get a precedent history of angina, you were a bad doctor, you go talk to him again. We didn't know that a large number never have angina. And the reason they don't have angina is they don't have a narrowing. They have, well, not a big one, not a 70, 80, 90% narrowing. They have a 40% narrowing that suddenly erupts. They're still dead. These are tests that are predictors of heart disease. The first one is the protein in the urine we talked about, and the second is the stiffness of the wall of the heart. These are screening tests. We're not going to go through them all, but they're out there, and we actually use them every day. These are part of the information backgrounds.
Excuse me.
Mm-hmm.
What's the one on the earlobe crease? Because I've noticed that virtually everyone has an earlobe crease on the left ear.
Yep. The chronology is that everybody had a crease. And then they said it has something to do with heart disease. And they said, well, no, it's a smoking that the people do, and that causes ear creases. And then they came out and said, no, it's probably real. I don't know where it is now.
It was first discovered in a Swedish intensive care unit, and it has to do particularly with the angle of the ear crease. And there was a statistical relationship between that specific ear crease and the presence of coronary disease. And the thinking is that the gene that causes that ear crease sits next to a gene for heart disease. So the ear crease doesn't give you the heart disease. it's just a marker that you probably have something else. And I forget which way the photography slope went. So one way it's okay, the other way it's not. We have to go look it up again.
But one way gay and the other way is a relationship.
Pardon?
I was taught there's about a 60% relationship between air increases and heart disease. Is that about it?
I have no idea.
Yeah, the stuff I'm familiar with is from Sweden a number of years ago when they first discovered it. And in the intensive care unit, it may have been 50 or 60%. But what it is in the population, I'm not sure.
Yeah, I was taught it was 60%.
What it would bring up, of course, is if you did have that genetic abnormality, you want to pass everything else. Because the gene, you're not going to modify it by any way we understand right now. We're going to end here with CPAT testing. CPAT testing has been around for 30, 40 years. It started by Wasserman, at least he popularized it. He was from California. And the issue was the exhaled gases can tell you a lot about the heart and lungs both. There's 26 different conditions that are known to be diagnosable by this kind of a test. You've seen this test sometime if you've been watching TV for a while, because back when Lance Armstrong was racing the Tour de France, he had kind of an information thing would show up every fall or before the tour of him training for it. It was similar stuff, but it was always involved him riding a bike with a mask on. Why did Lance need oxygen? He didn't. That's the test. So he was doing this test on himself every single day. Well, call your attention to that center top slide. The blue line comes up, goes sideways. The red line comes up, and at the same time the blue line goes sideways, the red line goes up. Red line is a heart rate, the blue line is a squeeze of the left ventricle. What's happening there is, at that particular point where those two lines bifurcate, the left ventricle has run out of oxygen. It's going into heart failure. Now, not the kind that gets people in the hospital, but it's still heart failure. The heart will compensate for the decreased squeeze by increasing the rate. It's rate times output equals volume. So there's a compensatory thing there. This is highly reproducible. It's extremely accurate. It demonstrates small vessel disease. Back in the day, we didn't know there was small vessel disease, but there is. It's an endothelial process, and it is a diagnostic for early heart disease. So these are a whole bunch of different slides, but the CPAT study, that one, is by far the most accurate. Now, why do I make a point of this? Because calcium scores and everything else are anatomical. This is physiological. Tells you if the thing's working right. And magnified, look at the same thing. Now you can see you would make the diagnosis with a straight edge ruler. You take the straight edge ruler, run it up the blue on the bottom, and just draw with a pencil. You see where it's supposed to go, and you'll find out it actually goes sideways. And in this case, the red and the blue are interposed. They don't have to be. But you do the same thing in the red line. You'll see exactly at the time the blue line goes flat, the red line goes up. We find this on 60 to 66% of men. The vast majority of them, again, don't have any symptoms. We also measure an EKG, a stress test, at the same time, because we know it's got 11% hit ratio, no matter how you're doing it. If the person has an abnormal ST segment, which is the EKG part, and this, we get to send them across the street to our cardiologist, and they'll see them that afternoon, because we don't know how mature that problem is at that point, but it's not cool. There was a study done called the Courage Study, which is, they make the names of the studies out of letters that they pick from what they're researching. The Courage Study was courageous. They took people basically with 70% narrowings, and half of them they angioplastied, and half of them they treated with medical therapy. And then at some point they broke the code to find out what was his correct approach. It turns out angioplasty kind of wasn't. And the reason is if you have 50 narrowings in the heart, one of them is 90%, and you open that one up, what'd you do for the other 49? Nothing. That wasn't a good idea. If you were treating the whole person, they were all getting better. So now the cardiologist will definitely do the angioplasty and stents, but they also follow it up with what they consider to be maximal therapy. Some of us don't consider what they do to be maximal therapy because they don't personalize it. But in any case, the COURAGE study took a lot of courage to pull off, and they did it. This is a nuclear. The machine can make any part of the heart any color. It can be black and white, orange, pink. They tend to like purples and oranges together. And you have a resting tracing on the left here and a stress one at the right, at the top. And they should be identical. If you go to the right side, the top two under stress don't look like the bottom two at rest. Something has changed there, and that's because there is a decreased blood supply to whatever segment that is. This is very important for deciding on surgery. It does not tell you if the person has heart disease. That's a whole different issue. The old-fashioned treadmill test, we've all done thousands of them, and the problem was, again, it was not diagnostic for the disease process. It would pick up high-grade lesions. If you're taking a picture of the heart with ultrasound, the beams of the top is looking down to the long axis of the heart, and you want the heart to squeeze the same all the way, all the time. The squeeze between these bottom two pictures, you can see there's a bunch of arrows in there. That portion of the heart isn't squeezing like it did before. So that part of the heart is not getting enough blood supply. Again, this is used for staging for surgery. Bypass grafting, terribly effective. Kind of hurts a little bit. We used to think back in the old days, the more bypasses they put in, the worse the disease. Actually, it was kind of different than that. Now they put in a whole bunch of bypasses because they're just good at it. So they can drop some more bypasses down. And the one drop down for there are different kinds of bypass grafts. The issue at this time is, what are you going to do with the person after you've rescued the arteries? And that's maximal intensive therapy or medication therapy. They get the artery, they borrow it from another structure and sew it in. If you don't do it right, this is what a code blue looks like. It's called the advanced cardiac life support. This is what Dr. Pinnell puts on the airplanes. He actually puts together the kits that are used in corporate airplanes and trains in their use. Most of the problems with emergencies on airplanes are fainting. And of course the problem is when someone faints, the people around them want to keep them up in their seat. Well, that's why they fainted. So you got to get them out in the aisle and get them down, and the air crews know to do this. And then that's why diversion becomes a big deal, because if you can get the person to wake up just by putting them on the aisle, you don't have to divert and spend tons of money for gasoline. The people that will be talking, Peg will be talking this afternoon, and we have folks that can answer, excluding me, about any question you can possibly think of, including Doc's wife, who's out front. So we thank you very much.